ngā rongo ki te whenua e whakaro pai ki ngā tāngata katoa āmine. E te atua manakitia mai kia mātou I tēnei rā. Manakitia hoki e tahi o ngā whānau e māwiwi ana e noho pauri ana I tēnei wā taumaha kei wanganui a mātou. Tēnei tā mātou ine o kia koe. Āmine. Kia ora everybody. Welcome to our May meeting of the board and being our second to last meeting of our term. Welcome also to members of the public or the media who are joining us on live stream. It's good to have you again with us today. We'll start going through the sort of administrative parts of our meeting once the papers organised. So we have to say apologies from Sandra and Robin has another commitment and needs to leave us a bit early today. Item 2.1 is our schedule of interests for review. If anyone has any changes that need flagging, they can do so or else email them through to Rachel. Does anyone have any conflicts in relation to today's agenda item? No? Okay. We'll move then to the minutes of our previous public meeting on the 26th of April, which are at page 7 of the board pack. Does anyone have any corrections to the minutes? Okay, we will note and accept those minutes. And any matters arising? Okay, and we will go to the action items which are on page 12. And Jim, if I can pass to you for the action items, please.
Yes, so there was just that one there around the dashboard and the FCT data, and that we think was just a timing issue in terms of what's in the dashboard compared to what was in the report.
Okay, any questions on that one? We have no correspondence in the public session, and we'll move to the performance dashboard, which is on page 13. And Jim, if there's any particular issues you'd like to highlight on the performance dashboard?
Yes, I would like to highlight the continuing poor performance around vaccinations. And we had the immunisation steering group meeting yesterday, at which we discussed those, and not just childhood vaccinations, but also measles and COVID as the whole picture. So we've got some work going on around revitalising that for Tairāwhiti across our providers, and seeing if we can get those rates to come up. There has been a small improvement in the last 2 to 3 weeks with the extra work that's going on between our outreach immunisation service and Tūranga Health. That's for childhood immunisations, and there was a very successful hui with Ngāti Hauora last week, yes, around applying a similar technology with them as well, to be able to improve rates there as well. We've also had some discussions with Plunkett, but that's not progressed as much yet for the whānau enrolled with them. So yeah, definitely an area that we're working on. We do note that our rates, you may not believe it, but our rates for Māori and Tairāwhiti actually are slightly better than the national rates, but we're not resting on our laurels in relationship to that. I think the other area there, we've still got that persistent problem around primary care with Better Help Smokers to Quit, and that is just fundamentally because people aren't going into primary care to get that advice at present. So not sure when that will improve. And generally those ones which require people to come out and about, like cervical screening and breast screening, are going through that lower period at present as a result of people not coming out and about for those sorts of appointments. Those indices around the emergency department weren't met, and we've got quite a significant increase in numbers of people coming through the emergency department at present, and the hospital has been quite full over the last week or two, as well as we're starting to see that winter effect coming through.
Could also be related to being unable to get into the GPs, as we know from an experience we had yesterday.
True.
Can't get in.
Yes, and that was another topic that we had a conversation about the Immunisation Steering Group yesterday about access to general practice and what general practice is doing to improve that. And I've got a discussion with Clayton Kohatu today, clinical, around not just that, but generally about what's happening within primary care. Because yes, it's a very important factor in the need for people to come to the emergency department. I mean, you will see later on in the graphs, generally the numbers of people coming to the emergency department is down, but it will start to increase again over the coming months. First day of winter tomorrow.
And a situation we had yesterday was the person wasn't enrolled and they needed to be seen urgently, but you couldn't enrol and be seen until your paperwork from your previous practice had come up. So if you're from out of town, it could be a week or two. But I didn't know that was a rule, and I don't think it is a rule. So maybe that's something you can remind them that if they enrol, they should be able to be seen, even if they have to pay the higher rate, but they won't let them in.
Yeah, well, that's a misunderstanding of the practice, because there's a clawback on that anyway with the practice that they are.
Yeah.
So to give them more space because they don't have any appointments.
Yeah.
And that was two of the practices we tried to get into.
So, Jim, you kind of also canvassed a number of the issues that are in your CE's report. So I wonder if we should complete your CE's report and then go back to Chair's report after that.
Sure. Okay.
Right, Madam Chair, can I just ask a question for clarification?
Yes, certainly.
Sorry, I'm just on bandwidth, so I'm off screen.
I recognised your voice.
Yes, it's not unlike me. I'm just interested in your comment. Oh, golly, sorry, I'm on puppy duty at the moment. He's found something. I know. Should add it to the attendance list, I suppose.
What's her name?
Athena.
Athena. Okay.
Yes, which comes from her grandfather, who was Zeus. Anyway,
okay.
the real whakapapa thing going on here. Anyway, back to business, Madam Chair. Sorry, Jim, your comments around. Can I just ask you the 90% of the smoking target rate? Is that for people who attend a surgery? That's not 90% of the population, is it? That's just 90% of people who come into that service, isn't it?
Yeah.
So the corresponding reads then suggest that whoever's turning up is not being attended to. Am I right in that?
I think it's more that they haven't been through the process.
They haven't been to the practice.
They haven't been to the practice.
But if they turn up on the day, that's what that 90% is saying. 90% of the people that turn up on the day, or whichever day it is that they turn up, they're not being offered that, or sorry, 67%, whatever it is. Only 6% or 7% of the people that turn up to the surgery or the practice are offered that advice. Have I got that right?
No, it's of the total people in the practice who are cigarette smokers, who are identified as cigarette smokers, every 15 months have to be provided with brief intervention smoking advice. So that's the measure. So 90% of those people enrolled with the practice who are smokers provided with brief advice every 15 months. And so people are not getting to the practice to be able to, so it's not necessarily people who turn up not getting it, it's just in general people not getting it.
I suppose there's a double-edged sword there. I'm just thinking to myself that some people don't turn up for 2 or 3 years, so we're never going to get anywhere close to that target. And I just wondered whether or not, for the ones that do turn up, how do we solidify that number of people against the 90% of the people that turn up, rather than the people that are sitting on the register? So just posing a question, that's all.
The target is supposed to be proactive, so the practices are supposed to be contacting people regularly to provide them with, some people need their screening advice and, other things they need. And as part of that, if there are people on the practice register who have identified as cigarette smokers, they need to be contacted regularly to provide them with, hello, brief advice. Would you like to consider quitting? Etc. They're supposed to be contacted to do that. Practices are able to contact people at least once every 3 years because they need to do that. Otherwise, they won't be able to keep on getting funded for those people.
Yeah.
So they are able to do it every 3 years. This is a little bit shorter than that, and it's only these group of people who've self-identified as cigarette smokers.
Have we ever taken, I'll use the word lightly, action for, because these I get, two practices that haven't met the target. The only reason I ask that is because I don't think I've ever seen this target ever reached, ever.
It was
I don't know.
Pre-COVID days, it was up pretty much. I don't know if they ever got to 90%, but it was pretty close to it.
Okay, well, all right.
Because it's a subset of the practice. It's not everybody that. I mean, some people will come in anyway, so they get provided advice when they come in, and and as a general population, more likely for that group of the population to be coming into primary care anyway. And then on top of that, they were specifically contacting them. And some of the practices had subcontracted that. I know that one practice subcontracted that to Tairāwhiti Health to do that, to contact the people. So, and often those people will be on Tairāwhiti Health's registers as well. So they were, that worked out well to be able to do that. So there's ways of doing it. It's just that most of those ways have dropped away.
It should be as easy as any recall.
Yeah. I suppose the point of my question really is how do we reactivate that and re-encourage practices to do that, mahi they're contracted for, or whomever.
Yeah.
Particularly in light of the, those are pretty low stats. And if you look at immunisations, we're in the same predicament there as well, I presume.
Yeah. Sure. So, I think probably the model is not right for either of the two instances. We know the model is not right for the immunisation, so we're working to change that.
Yeah.
One around smoking advice probably isn't right as well. And to be fair, a lot of those people are probably getting smoking advice through other different channels. It's just not getting registered on the practice register and on the practice register that person's been provided advice at the practice. But with many of the programs that particularly Ngāti Porou Hauora and Tairāwhiti Health are running, that advice has probably been given, and people are taking options up. Some of the programs that are happening there, but it's not captured within the system.
Yeah, and it's that capture that's the important part.
Yeah. So in some respects, this indicator is possibly not so good in that it's in that era where everybody goes to their general practice and everybody gets their healthcare services from their general practice. Well, that's just not what happens in the 21st century.
Mm-hmm. Oh, well, I think I'm encouraged by the fact you're looking at the model and how that might evolve as everything does. So, kapai. All right, thank you, Madam Chair.
Kapai, thank you, Nga.
So back to you again.
Back to you if we finish off the Chief Executive report.
Yeah. So not such a good financial result last month. So we've got a negative variance last month, but we are still on track to be around about budget at year end. Is a bit of coming and going in there, particularly with COVID funding in the month, and so we are still wanting to track in that direction. Well, not wanting, but expecting to track in that direction. And Kath's, apologies, she's a little late this morning, but she'll be coming along shortly. She's on a video conference around day one financial arrangements. As I was saying, we've certainly had, with the effect of the last few months around COVID in the community, a reduction in the numbers of people coming through acutely to the hospital, but you'll see there's a small flick up there in last month, and we definitely will see a much greater increase in the numbers of people coming through the hospital this coming month acutely. The last probably 2 weeks, most days the hospital is over 90% occupancy. And certainly this week as well, we've been able to maintain our planned care through that period of time. At present, we haven't had to reduce or stop planned care over that period of time. as yet. And you will see that on top of page 17 that we're continuing that general downward trend that we've had in acute medical admissions over the last year or two, and no doubt aided and abetted by the reduction in transmission of diseases in the community. And we've got a lot of work going on around planning for winter this year, taking advantage of people's upskilled knowledge of public health measures that can help them in terms of staying at home if you've got respiratory illnesses, mask wearing, hand washing, those sorts of ways of counteracting the effects of winter. And so we are trying to make winter better, but at present it's still showing up in numbers of people coming into the hospital, and trying to make winter better definitely for children. And we're concerned about the exposure that we will undoubtedly get for our youngest part of the population around RSV this winter as well. So that's part of the winter wellness planning. You will, I think I might have mentioned last month that we've been requested to leave in place functions such as the Takatu Hub over the winter time, and we've had a number of discussions around that. We're hoping to engage iwi around that today, but unfortunately they're going to be busy with ministers in town, so we'll definitely catch up with them as around our functioning and considerations for the winter. And we have rolled over all of our contracts around the functions of Takatu Hub until the end of the year to be able to make sure that we have that support in place for people. And I'll probably come back to that a little bit in my discussion around COVID later on the agenda. So those are the graphs around admissions. You will see at the top of page 19 is what I was talking about the reduction present around the number of ED arrivals, but you'll see in the graph next month that will take a sharp upward spike with what we've seen over the last few months. Other things we've talked about, some of the indices there, similar problem around better help for smokers to quit, and needing to make sure we do more within the hospital setting and the community setting around that advice, and not just in the community setting, but in the hospital setting as well. A really good month for people's access to cancer treatments. We have reset the process around the whole monitoring around the flow of people through cancer treatment services with Tairāwhiti, the Cancer Control Agency, jointly with us. And so that's across the whole of Te Manuataki, but for our own devices to make sure that we are following that through better. And we've got have utilised Tairāwhiti to do a review of our cancer services here in Tairāwhiti, and we expect the report on that to be available not this month, in June. Immunisations, we've talked around those.
Can I just, probably a couple of things on the immunisations. Firstly, and I'm presuming this is still correct, I think it's important just to remind ourselves that, for example, at 8 months, if you're immunised at 8 months and 10 days, you don't count in the 8-month immunisation. So it doesn't mean you're not immunised, just, for some people it could be late. And also we've got very good rates for our Pacific and Asian parts of the population. And I'm wondering if there's anything that we can learn from why they are immunising their tamariki at such good rates. Like, what's working there?
I don't know that there's, yes, there's, yeah, I think Pacific population quite a cohesive population. Yeah. And I think that another factor will be the experience, the very tragic experience of people in Samoa, for instance, around when the virus was exported from Aotearoa to Samoa and had such devastating effects on their population. So I think those things, sad to say, but some good has come from that, and that people have understood that better, and we do need to spread that knowledge more widely around that, those things that we can learn. I mean, we know that immunisation works, and we've got ample proof of that. We just need to make sure that people have got access. I think a lot of it is around access.
Okay.
Okay, so we've talked probably much about throughput. Planned care production. So we're just a bit off the pace around planned care production. As you know, we had a period of time there, of at least a month or two, where we were tailing back on planned care production as we prepared ready for the COVID wave as it came through and the effect of that on the hospital. And so we lost some production over that period of time. We've been able to, we haven't started to catch that up yet, but we certainly in last month able to stop the slide against those volumes, and the performance that we've had is not good enough, but we need to, and we can improve on that, and which is what we're concentrating in on at present. And so it's good that we've been able to maintain the production rates over the last few weeks as we've had more people coming through the hospital. We are going to receive all of our funding for planned care for this year. So we've worked through that with the Ministry of Health around our overall production there in terms of over delivering on FSAs against under delivering on procedures, and so that's proved acceptable to them. You can see that on trajectories, we've been able to change the trajectories in a few areas, but some are still persisting there. I'm very confident in some of those areas that we'll be able to fix them, such as in general medicine and gynecology for FSAs, for instance, where we've got local capacity. Some of those other ones where we have where we utilise outside, such as neurology, are more difficult to get under control, although small numbers in that area there. And ophthalmology, we've got our 2 ophthalmologists now, not quite seeing the impact of that yet, but we've got some more work to be able to see if we can improve that situation with that increased ophthalmology capacity that we have got. So yeah, so we had a slight improvement around total numbers of people waiting for an FSA more than 4 months, from 514 down to 475. We expect that to continue to improve. I think the other and flat on SB5 people waiting for treatment. But you can see that in the system there on the top of page 25, we've got a huge increase in the numbers of people in the system. So we've since that graph started in December 2019 to the present date, we've almost doubled the number of people within the system waiting for treatment, and are still and haven't really changed much in terms of those waiting longer than 4 months. So it's an awful lot of additional capacity and delivery that has occurred over that period of time, but not enough to take it back down to 0. You can see that around about September last year, we were almost back to 0 around SB5, but it's crept back upwards again since that period of time. So we can do it, and we'll get back into doing it again. And we've got the Planned Care Task Force, led by Andrew Connolly, has provided us with 10 or 12, I think it is, helpful ideas about how we can approach this. And we're also charged with looking specifically about those people with longer waits, around putting a plan around those people. We believe that for us, particularly around FSAs, that our data is not very clean on those. So we've got a project coming up in about 2 weekends time where we're going to ring everybody that's got a longer wait, just to see what the story is with them, because we believe many of those people would have actually had some have been sorted out in some other way, but we just need to know if it's still an issue for them. We talked about the emergency department attendances. And then later on there's just a few more of the usual reports and links there if people are interested in those areas. And then finally, at the end there's just a few discussion points. We have already talked about vaccination and the work that the Immunisation Steering Group is doing around that, and the resources that we're going to make available around that. We've increase the amount of people working within the outreach immunisation service so that we can make a particular bid around those children waiting. Isolation and quarantine facilities, we've had clarification from MB, who are now the people that organise and run that service, that the expectations is that we will maintain capacity for the coming months. We being they will maintain capacity for the coming months, and so we can make sure that they do. We don't need as much capacity as we have previously had, so we will be able to return some of the camper vans, repurpose the utilisation of the hospital flats, etc. But we still need to keep some capacity over the winter time. Mental Health and Addictions Facility, well, at 10 o'clock we've got a presentation coming up about that. Child and Youth Hub, I've just signed the contract around for the architects on that piece of work. Recruitment, still a problem area, and there's a paper in the agenda today where we can talk about that when we come to it. Industrial relations, it's very pleasing to see that we've now achieved a settlement or proposed settlement with the PSA for our allied health and technical workers. That is out for ratification. I think the meetings are being held this week, so that our staff members who are members of that union can vote on that coming up soon. It's being recommended by the union, so it's likely to be able to be ratified. And also you would have seen or possibly hopefully heard that the pay equity settlement with our admin clerical workers was ratified by that membership about 2 weeks ago, and so that is in the process of now needs to be implemented. We all need to spare a thought and say thank you to our payroll team. They have got work to do around implementing that pay equity settlement. They've got the allied and technical settlement to implement. We are expecting at some point there will be the nurses settlement agreed. You may have caught up with the fact that the nurses organisation and the PSA have decided to go to the Employment Relations Authority for a judgment around a couple of the aspects of the settlement that they don't believe are appropriate. So that means that there will be a hold up in that until that is pronounced. We have to go into mediation prior to that to see if we can get a settlement without having to go to the ERA. And so just two things. It's a busy time around industrial relations, and B, it's going to be a busy time for our payroll teams as they implement all of these agreements over the coming months. Believe also that we are poised to get a settlement with our senior medical staff as well. Oxygen and environmental, we have got all of the drawings for the second phase of our reconfiguration of the hospital to make it better in relationship to this current pandemic and future pandemics, and just need to get those signed off. The site reconfiguration work is proceeding on. We have got Singer, the contractors around the pipe work, etc., the steam supply, etc., now locked in and commenced work. Winter planning I've talked about. ED facility is part of that oxygen and environmental work. The generator and electrical upgrade, that is also Singer. Reforms, I've got a couple of slides coming up, which I've tacked onto the COVID presentation for you around that. Icu staffing increase, I'll mention the fact that we are to receive $2 million per annum to improve our intensive care facilities here, not facilities, our intensive care capacity here. That's $2 million a year for additional staff. It's going to take our number of critical care beds up by 2 to make it 5. So we will, in our current intensive care coronary care unit, will have 5 intensive critical care beds and 1 high dependency bed in that. So that's a substantial amount of additional funding. It's going to be phased in over this coming financial year and the second financial year. We will get the full $2 million per annum, and the the big factor on that will be to recruit and to train up. So there's money for training for more nurses to work in that area as well, and also more allied health people to support that work as well. And regional services planning, we are that is being led strongly as part of the work of Health New Zealand and the changes across the region. So so there we have got teams being set up to look at a variety of services and how they configured across the whole region. That links back into capital requirements as well. First up is mental health and critical care, as those two. Mental health, every one of the Tairāwhiti currently DHBs is got a building project going, and so linking those up in the model of care. It'll also be aided by the fact that we received approval from the Ministry of Health around the new patient, the electronic health record in mental health services, so that will link up much better across our region. And also, so others are around cancer treatment, renal, I think there's about 3 or 4 of them. And Anil has been our lead person in that, but will expand out very much in the coming weeks as those teams of people looking around those areas for Te Manawataki get their work underway. And there's a regional workshop on the 15th of June to set that process up and get agreement about how it's going to be run across the region. And not on that list, but I just mentioned the fact that we'll be replacing our financial management information system. The whole country is going over to use Oracle system. That's not a surprise. So we are one of the 4, I think, last DHBs who will be doing that. We need to change over at latest by the 30th of June 2024. It's been my suggestion that we just get on and do it as quickly as possible so that we link up in one national system for that. So the days of Tech 1 are over.
So just to ask for any questions or comments from board members. There was just one thing in your report that I did want to echo, and that's it's the acknowledgement of Matt Tong passing as clinical lead. Matt's been wonderful to work with. I've got to know him a bit during the very many IMT meetings that we had during heights of the pandemic, and so I did just want to formally acknowledge his work that he's done as clinical lead. And so now, do any board members have any comments or questions of Jim regarding his report? Anyone on Zoom?
I do.
Heather.
It's not a reflection on the DHB, but it seems crazy that $2 million are going into ICU when people can't get into a GP for high blood pressure or poorly controlled diabetes that are going to end up in ICU. You probably wouldn't need it quite the same if we could put the effort into the primary care. And I'm not saying it's our choice, it's just the way it's all set up. We're packing it on the secondary care side when it really needs to be packed more on primary care. Going forward for anyone who's in the new health structure.
Yeah, and you know, the point that you raise is one of the emphases in the health reforms about community and primary health.
Yep. But, you know, I was just sitting here thinking $2 million could do such a lot for access to primary care.
Yep. And I think that's just really indicative of the whole problem that we have as a country, is we've underinvested in our health system over the years. And yet I'm not talking, I'm talking, decades of time. So we've got an infrastructure within our hospitals that is not fit for purpose, and we've shown ourselves up very much in the COVID pandemic that we just don't have enough proper ICU capacity within the system. So it's kind of like, what do you fix first? And with the sort of immediacy around the pandemic and the possibility of further pandemics, that it's been chosen to spend on that. But as you know, there's also funding going to primary care as well. But definitely there is the issue around pay parity is a significant factor with primary care and with aged residential care. And there's commitment from government around that to move on that as well. But not as immediate as that $2 million there. in the in critical care.
Any other comments?
Meredith.
Meredith.
Morena koutou. Listen, for me, I'm just wondering about, following on from Heather response, because that's a lot of feedback I get is that people aren't able to get into their primary care in 2 weeks down the road kind of thing. So people are less inclined to bother going to an appointment, et cetera, because they generally want to see the doctor straight away. But in the new iteration of health, is there a lot more talk around promotion, health promotion, what that looks like? Because they've done this amazing COVID response framework where we were seeing that regular and seeing the impact of that message. So is there a real realization that we actually still need to promote what healthy lifestyle, the whole framework of being well, eating well, etc., so that you don't end up, as you say, in ICU. So is health promotion getting a significant fund framework in this change up?
The recognition of health promotion and health protection, public health, has been recognised. COVID showed that the resilience within the system for that area of work is low. So the Ministry have provided additional funding across the country to increase our resources in that area. And we're continuing with partners around that workforce we brought on board for COVID to help fill some of the gaps that have been identified in that space.
I think too, Meredith, you're going to, there's a lot, in short, there is a lot more investment in that area, but you're going to see that in a different fund. So you're not going to see the traditional, let's have an advert campaign on TV, let's print some brochures out and put them in people's letterboxes. It's going to be much more targeted. So what we know from working through COVID was that, where the messages are taken out by, people such as Ngāti Hauora and Tūranga Health, and are there at grassroots level with the whānau, that's where you get the biggest improvements in health outcomes for people. I guess we've always known that, but we've just had that confirmation around that with the COVID period of time and the comparatively compared to other countries, lower impact on the population from the pandemic. And so that's where the investment is being made, and the other sharp end of that will be in relationship to the locality work and the iwi Māori partnership boards. So the funding has gone into there as well, and we are. I know that our locality arrangements will be signed off reasonably soon there, and that will definitely be a focus of that work there as well. So really getting down to grassroots about what works with whānau, what works with the population, rather than that old-fashioned traditional approach. It's a good message, so we'll just stick it out on billboards and everywhere, and people will read that and say, yeah, oh yeah, I get that now. I'll get my vaccination. Oh yeah, I get that now. I'll stop smoking. Yeah, it doesn't quite work that way.
No, it doesn't. And I guess you're right. We are seeing more, a movement forward to be a little bit more savvy in this space. I bring it up because I'm still teaching in schools, puberty talks and stuff like that. And I get an opportunity to talk about dentistry or oral health, et cetera, et cetera. And so I was thinking about that promotional space of at a young age, be it in kindergartens, primary schools as well. So thanks for that.
Okay, thank you, Jim. So we'll just get back to the other bits in this part of the agenda. From me, my report this month is very much a report of final things being done. So we have the final meeting of Te Manawa later this week over in Rotorua. So that meeting will have a bit of a focus on the equity work that we've done, the future of Te Manawa under the new health arrangements, and also celebrating our regional efforts. We had the final meetings of our subcommittees last week of Hiwa Itirangi and Finance, Audit and Risk, and Te Waioro Haememeha has its final meeting next month, and also the handover to the incoming iwi Māori Partnership Board. Ditto, we had the final chairs meeting a couple of weeks ago in Wellington, which was a bit of a reflections meeting, I guess. That one really. No ministers' meetings in the last fortnight, although we are still currently scheduled to meet with him on Friday. And then over the coming month, it's really just winding things out and trying to do what we can to make the transition as smooth as possible. From most of that work will actually be done by management, so you know, there won't be a lot of call on the board, but there will be some things like, you know, relationship handoffs and that kind of thing that that I will need to be attending to. We do have a paper a little bit later on in the agenda about our sort of transition checklist of things, and you will see on there that there are quite a number of things that we're still awaiting guidance from the centre on. You know, we had hoped to have had that by now, and I understand that it will mean some pressure on our staff to get things done in what will end up being quite short order. So we need to be conscious of that heading into our final board meeting, that I think it will be quite a busy sort of transition month for the staff. So that's about all for me, unless anyone's got any questions. Oh, okay, Nah, if you're still online, I'll pass over to you for the Hauora Nukutai Miha report. You're on mute, Hua.
Kia ora, everybody. I can't report on those matters, Madam Chair, because they're all in committee, so they'll come up in our in-committee session. I did want to, though, just say we're planning a bit of a shindig for our final Te Waioro Nukutai Memeha Hui on the 21st. So I just want to take this opportunity to just invite the board, if they would like to come along and help us close up Te Waioro Nukutai Memeha. As a board, you have been very supportive of us, and I just wanted to repay that mihi to this board and previous boards, but certainly as an outgoing board, I think it'd be quite nice if we were able to also make mention of our board in respect of the tautoko we've received through Te Waioro Nukutai Memeha. So this is the bit where Jim says, "No, you've gone off script." He has to readjust the catering and stuff. So.
He'll be right.
But anyway, we'd really like the board and ancillary staff, of course, if you could come and share a cup of tea with the crew and just close that up properly.
Kia ora, thank you, Matt.
Thank you, Madam Chair.
We have the financial report, but Kath isn't with us at the moment. So this was discussed at FRAC last week. Is there anything you want to raise on it, Heather?
No.
If Kath comes,
Yeah, she should. She said it.
We'll
She should be
touch
here by
base on it.
10:30. So.
I don't think there's no big surprises in here for us. I guess we all do note that our deficit position is deteriorating a bit, but it is certainly a whole lot closer to our agreed deficit than we have had in previous years. So we'll just park that one for the moment. For our subcommittees from last week, there's no items in this coming into this public session. Jim, do you want to do the COVID update now, or do you want to do it after the mental health?
I could do it now because we've got 15 minutes, okay. And it certainly won't take that period of time. I'll just see if I can get it up on that screen there. Yeah.
Yeah.
Yeah, the coast. It's
He's underwater.
That one there?
And well, that's confusing.
Yeah. Okay. So this is a little bit of a combination here around COVID and health reforms. So that's our current impressive looking graph around numbers of cases, of reported cases of people in our community. And so just the usual caveats around its reported cases. So we know that there's very likely to be more people out there, A, who haven't tested at all for their current respiratory illness, or B, who have and haven't then gone on to report their illness. But you can see that while we had a little bit of an increase around here, which was around that 2 weekends in a row, 1 weekend in a row, and at the start of going into orange and people taking their masks off, etc., we had a little bit of a rise at that point there. We are now appearing to tail off a bit in later weeks. So this is the sort of, and I'll come across to projections for the rest of the year shortly, the sort of picture that we're expecting. And this one here, which is one I haven't showed you before, which is really just looking at the rate, the number of cases per thousand in the population. So same data, but just in that, looking at that and the per head of population.
Jim, can I just ask a quick question there? Are our testing rates still up? Like, are we still issuing lots of tests?
No, we're not. We're not. I mean, I think we've saturated the market for rats, and so most people have got them available and can test when and as they want to. And just on this here, just looking at what that looks like across our age band, so you can see that very much the pandemic has been in these age groups here, the younger population, and then fortunately, and of course by design, very much lower in the older populations, and all of the rates, all the rates went up in those periods of time there, so it wasn't confined to any particular area. It proportionately a little bit higher here for our older population, but possibly that's the bunch of people who are still faithfully testing and faithfully reporting compared to the younger populations. And then what it looks like from an ethnicity point of view. So we had the big early on peak in our Pacifica population here per thousand population. And, so we really noticed that, and Heather will attest to the fact that age residential care, Heather, a lot of workers in age residential care from our Pacifica population. So it's had quite a big effect within residential care in terms of staffing. And then it's obviously dropped away here now. And so then the other groups within our population peak for Māori, and then everybody's pretty much in the same lower phase now. This is coming back to our usual graph around modelling. So that's a couple of weeks ago now we went through that thing, but you know that we'll be back down the road from here. So the modelling here, so we're well above again. That was modelled around PCR testing. So you can see the huge difference it made to actually get rat tests available for the population. Rats less accurate, but definitely got more people testing and able to show, to give people a good indication about whether they're positive or not. And then that steady line, the sawtooth being the Monday Monday to weekend effect, still carrying on. And the country, so much closer to the modelling. I don't know if you can see on that graph, those that are colourblind like me, there it is there. So the whole country was very much on target in terms of projected number of cases, but that much more to the right sway on that and the same national testing pattern, cyclical weekly testing pattern there. And this is our bed utilisation, and I think on that graph we've got 5. Just at the weekend we had 6. people in the hospital with COVID, and we've actually got 2 people in our mental health facility at present who are COVID positive. So a little bit of a change there as it starts to disseminate out more widely within the population, but definitely tracking along that lowest or lower than the low of on the projections there.
Jim, are the 5 in hospital, were they hospitalised because of COVID, or they were hospitalised for other matters and they happen to have COVID?
I haven't got definitive figures, but I'd, just off the top of my head, I'd say around 80% of the people hospitalised are people incidentally positive to COVID, so tested when they've come here for some other reason who are positive, but definitely at present we've got some people in hospital who are absolutely here because of their COVID illness. Which graph am I up to? Oh, that's beds still haven't gone on. Yep. Okay. So here's a few scenarios going forward for the rest of the year, bearing in mind that we are around about here at this point. So at present, we seem to be, this is utilisation of hospital beds, we seem to be, we're going to be up a little bit higher at present. I think that's the 5, we would be, or 6, we would have been up here at one point, but I think you'll find that's hopefully just an aberrant period on that graph there. So there's a number of scenarios encased in this. The one that's of course most concerning is this one here, scenario C, where we have a peak similar to what was forecast here, bearing in mind that we never reached that peak, and so we were much lower than the peak that was forecast here. So hopefully it will be the same here. This is a confluence of influenza admissions, RSV admissions, and COVID admissions through a second, third, or fourth wave, whatever you'd like to describe it, around COVID in the community, possibly aided and abetted by a new variant, more virulent variant, or as we know, we do know from water testing that we've got the BA4 and BA5 subvariants of Omicron in our population at present. So whether they cause more hospitalizations, time will tell. It doesn't seem to be the case yet, but time may tell about that. It would appear that those subvariants are better able to evade immunity that people might have, particularly immunity that they've developed from having the disease. So time will tell, but as you can see, our winter planning is keyed into those more dire projections, and that's just taking that a little bit down to what we're currently doing in terms of the 7-day average and what it appears to be tracking at present, which is getting down to roughly on average around about 30 odd new cases a day by July, and long may it continue to decline. I just threw this other one in just so that we're comparing with what we are doing with our cousins across the Tasman there. You can see that we, in the first case graph there around the cases per million, we had our peak a lot later than Australia, and we have had a picture of a lot more cases coming down the side. I suspect that was also the fact that we have very high access to RAT testing, which may not necessarily be the case in Australia, and reporting. So we've got, so that may actually be more like that as the deaths were certainly much more skewed. So that's possibly doesn't match with that. And nobody knows what that is. Just the crazy Australians. Cheap Australian jokes. And then so our death rates here, and we had that little bit of a climb there as the numbers of cases in the community started to tick up again, but that will have come down again now as well. So I've also talked briefly around vaccination and our efforts around to put that together in that more whānau approach going forward across the rest of the winter, and we're putting some more resources into that. Talked about takatū and sustaining that approach across the winter. How do you refashion that approach to provide support to people in the community? It's much easier when you've got a test that somebody can do that says, I'm positive. you know, I need some support, you know, and that person is able to identify and then go through. But when you've got a situation where obviously you can test to see whether people are positive for influenza or RSV, but you know, not as really available as a rat test, how do you then get people into that support system when you've got that change? So that's been exercising the minds of Ariana and Ian and the team at Takatu and our iwi about how we continue to provide that support in the community, because it's been so successful. And the what if at the bottom there is, if we approach winter every year with that in mind, what difference would that make in terms of not only for the health system, in terms of less people requiring care within the health system and needing to try and get an appointment at their general practice, and which would then leave people, general practice, able to deal with the ongoing health needs of people, but also what that would mean for our businesses, more productivity in our businesses over the winter rather than the usual, and our schools and access to the education system. These are interesting questions. And now just a few slides around the health and safety sector review and the implementation. As we know, we've got, it's 4 weeks to go on Friday till Health New Zealand and Māori Health Authority are here. The Pai Order Bill is back in Parliament and I think is pretty close to having its second and then third readings and being passed into law. Definitely that will be completed by the sometime in July, June, so that it's ready for July to be in place. This is the, I think I've shown you before, just a reminder around the structure of Health New Zealand with these single tier ELT with 3 sub-teams, 1, 2 and 3, and then this is to support the way in which the chief executive and the organisation works. So we've got the clinical leadership team here. I know there's been a lot of debate about midwifery staying in that box there. So what's that space? The delivery team here of the service streams around hospital and specialist services, and our national and the national commissioning functions. So the splitting up in the current system that we have now, they have been combined together in roles and functions, separate but combined in terms of DHBs having that dual function, but in the new system in Health New Zealand having those split out into those teams there. These roles, the National Director of Hospital and Specialist Services and the National Director of Commissioning, are advertised at present. I think close reasonably soon, so that those appointments can be made. There's also the inclusion of the new National Public Health Service within Health New Zealand. So all of the public health units around the country are being rolled in together to one national service, and inclusive of those people working currently within the Ministry of Health into one service for the country. And our teams here will be transferring over that, so it'll be a separate sub-unit within Health New Zealand and the National Director of Public Health, Pacific Health, as well as a work stream within there. There are some roles here that you can't see so well. That's the Executive Director of Procurement and Supplies. Again, that view that when you bulk everything together and you have one single national financial system, I've given the good news, Kath, that we're moving over to Oracle, that you can get benefit around running the system as a whole and generating savings from that. And that's National Director of Service Improvements as well, saying what can you do when you've got a single system, how can you look at what are the improvements and innovation that you've got already within the system and roll that out everywhere. And then we come down to regional level, same streams within that, hospital and specialist services, commissioning, and then Pacifica and public health at that level, and then at all points the intersection and the partnership arrangement with the Māori Health Authority. And then down at the local level here, at district level here for Tairāwhiti with that's a regional management board and a district management board, a regional management board here again with hospital and specialist services, the local district people around commissioning, the Māori Health Authority, the Iwi Māori Partnership Board, and the locality at our local meetings here. And then the enablers, there's a Chief Financial Officer. There'll be one single financial service of the country. So Kath and her team will be reporting in ultimately to the Chief Financial Officer for the country, Chief People and Development Officer, so our current HR, ER people, our People and Development team through Jenny will report through to the National Service, and our Chief Data and Digital, so our IT and technical service there will also report through to a national service. So different in that respect for those people that work in that area. And then there's the Chief of Infrastructure. So the many projects that are occurring around the country, linking those up through the Health Infrastructure Unit, which is already part of Interim Health New Zealand, and the support people there. And I've also remind you around the task forces that have already been set up under Health New Zealand's winter immunisation are really just one, but I've included the second ones there because they are two focuses within that task force: planned care, which Andrew Connolly is leading, and workforce, which is up and running. And I believe that the Chief Executive or current Chief Executive of Auckland DHB also is taking over a lead role for that in the interim period of time. Just really tiny, as the Health New Zealand is out there advertising the roles at present, similarly within the Māori Health Authority, those roles are in place. They need to be put, obviously these two organisations need to work very closely together. They're going to be housed in the same place, work together very closely, and so these roles here around, governance functions, Mātauranga Māori, strategy and transformation, systems policy, service development, and it's like relatives, but I'm sure that's not.
Relationships.
I have to read my slide, I will in a second. Corporate service, etc. Those people will work very closely with their counterparts within Health New Zealand. The word is relations. And then, as I said, the way in which Health New Zealand is going to work is already starting to have an effect here across Te Manawa. So there is the setting up of a regional coordination service under the lead Chief Executive there at present, but I'll follow up with that in a second. So this is really how the Te Manawa works as a region. So we've got the nationally designed, regionally delivered, locally tailored. So this is the regionally delivered piece of it. So how does the region work as a one cohesive group, and how do you have the systems in place to be able to do that? So this is the regional coordination service that is being set up to be able to do that. It's got a big focus at the moment around COVID embedded within it, and winter planning, because that's the most immediate risk for the population at present. But you can see that within this, around program management, around the data and intelligence that you need to work to do, the workforce that you need to secure across the region, etc., the communications that you've got the gradually developing and accelerating requirements around how Te Manawa will work as one of the regions of the.
So Jim, can you just clarify terminology on regional governance? Is that referring to the regional management board?
This is a slide that was developed in DHB land. So strike that out and put regional management board. Strike out lead Chief Executive and put in for the next 3 months, put the regional director. But in future that would be probably be the regional director of hospital and specialist services would be in that role, and then this over that. So what you're seeing is a lot of year one transition. And then a little bit hard to read, but just to note that as part of this transition, Margie has appointed a group of people as in interim roles within Health New Zealand, so that we can actually have a day one team there. So if you remember the functions there, so you've got the clinical leadership. So she's got Peter Watson, who's the current acting Chief Executive at Counties Manukau DHB, who was their Chief Medical Officer in that medical lead role within her team, and Dale Olive, who's the current Chief Executive at Wairarapa DHB, who's got a nursing background, has been taking the lead around nursing in the country there as well. So that's starting that clinical team there. Then she's got the delivery team here with Kellyanne Brooking, taking on a lead role for commissioning for that interim period, 3 months at present, to set up the systems and processes around the national commissioning team. So bring together the commissioning people within former DHBs with the team within the Ministry of Health that has joined them. Dale Bramley, who's the current Chief Executive at Waitanata DHB, as the interim Director of Hospital and Specialist Services. Geraldine Clifford Lidston, who I think works within the Ministry of Health currently in their Pacifica team, taking that lead as interim Director of Pacifica Health. Improvement in information, not maybe there, and Joe Gibbs has been leading a piece of work around the National Public Health Service, and Joe's been working in and out of the ministry and in Auckland DHB for a number of years, and has been talking with us about how the transition will work here for our team within our public health team here. The Chief Financial Officer is Rosalie Percival. Rosalie is a CFO of Auckland DHB. Yes, and has been in that role for a number of months now, leading that work. People and Culture with Rosemary Clements, who's the Chief Executive at Tairāwhiti DHB, who's been the lead for DHBs around future and People and Culture for the DHBs, and is now taken on that interim role there. Shane Hunter, who was appointed as the lead for data and digital within Health New Zealand, came over from the Ministry of Health, has now resigned, and so they're replacing there. And similarly, this role here around infrastructure investment. And Sue Gordon has been doing the back office work. Sue was very much involved in COVID response from the Ministry of Health for a number of months. And then a number of people in that office support for Margie, and of particular interest is this person, Alan Cassidy, there in that change management office role. So a lot of change management has to occur. So she's got Alan Cassidy, I haven't met him yet, but believe that he is quite dynamic and will certainly be helpful in that. And just in terms of this as well, there has been appointment of regional directors for each of the 4 regions in the country. So the regional director for interim appointments, so the regional director for Te Manawataki is Kevin Snee. And the regional directors move out of their current chief executive or soon to be district director roles. These are roles that regional directors and district directors are not in the new structure. So these are sort of former DHB type roles, because they are about commissioning and service delivery. So the regional director of Te Manawataki is Kevin Snee. I will become the district director for Tairāwhiti on the 1st of July for a 3-month period. And in the northern region, the district director is Fiona Dugan. Fiona is currently the chief executive at Capital and Coast and Huts DHBs. She's stepping away from that, going back to Auckland, and will be the regional director there. The central regional director is Russell, can't remember his name, chief executive of Whanganui DHB. And in the South Island, it is Peter Bramley, who's the chief executive at Canterbury DHB. And each one of those areas, where chief executives are out, they are being subbed in by other people as the district directors for that 3-month period of time.
Jim, does the director job cover the whole of Tairāwhiti, or is it just for the hospital?
Sorry?
Does the director role, does it cover the whole of Tairāwhiti or just the hospital?
The whole, yes. So it's the same as my old chief executive role, and my delegations and everything like that will remain the same as they've been previously as well. Including the public health, or separate? Yep, it will include that until the public health stream within the ministry is within the new Health New Zealand is set up. Just a couple of quick other ones. Budget, or the last one really, budget 22-23. So the main factors in there are the fact that former DHB's deficits have been removed, so there's enough funding in there to wipe those out. There's also funding on top of that for increased cost pressures increases and around about nearly just over $300 million worth of new projects, etc., that the government is wanting to achieve, which is their selected additional programs. And separate to the health funding is also the funding that's in there for the pay equity settlements for admin, clerical, nurses, midwives, and allied health, which will be phased in over the next year or so, and are billions of dollars as well. That's it.
Thank you. That was very, particularly on the reforms, I think that was very useful. So, good to see that. Does anyone either in the room or on the Zoom have any questions of Jim on either the COVID report or the information on the health reforms? No? Okay. So I guess just one thing in terms of what the public will expect to see on 1 July. Jim, do you have any comment on that?
So what's that?
On what the, although all of these
what will the public see on 1 July?
Yeah.
Nothing terribly much.
Yeah. Like they will still come to the hospital, they will still go to their GP.
Absolutely, and that's the message, of course, that is being given for the public to, to be assured that everything, the systems in place, and you can see that Margie has put a team in place to be able to make sure that there is that continuity around the changeover. I expect that there will be some discussion with around there'll be a bit of branding work and announcement of the real names of the two organisations within the next few weeks, and some formal ceremonies, etc., on the 30th of June and the 1st of July. We are expecting, or we're planning on some ceremonies here. Not too large, which is something to signify the end of the DHB and the start of Health New Zealand and the Māori Health Authority on day one. There isn't going to be a major rebranding exercise over that time. Gradually, the delivery of the new organisations will be rolled out across the country. So it's
so for the public, it's probably just important for the public to understand that that the immediate change is really organisational change, and the public-facing health services will be on a longer change and transformation trajectory than 1 July.
Yes. Year one is transition. Year two, transformation.
Okay. Right, yeah, we'll wrap that up, and I think we're probably now moving to our presentation on the mental health. Oh,
Yep.
Yes, we are. So I just want to introduce Nick Tupara and Dan Ling, who have come to provide this presentation here today.
Come and pull up a few.
As you will remember, there is a consortium of people who are involved in the design of the health unit, which includes Mode Architects, which are an Australasian company with expertise in design of such facilities across Australia and New Zealand. And they have a relationship with Architects 44, who Dan works for here in Turanga as a part of incorporating local knowledge and design thought into their work, and then also went as part of that consortium with Nick Tupara as providing the even more local and appropriate advice and knowledge into the design. So welcome to the two of you here today. The board have been very much a part of this whole project right from word go, or even before word go, when we realised very much that we needed to replace out our tired, dilapidated and very last century mental health unit and to create something better.
Just before you pass over, I think for any public or media who are on the live stream, it'd just be useful, given the sort of commentary we've had in on media platforms recently. If you could just comment on what exactly the Ministry of Health has approved and our kind of broad timeframe trajectory.
Yeah, so current budget $23 million, 23.8, near enough. And so that's gone up from the original, it went up last year with some additional funding put in there because of pressures around cost growth within the building industry over that period of time. The time frame for this now, my understanding, and I'm about to be corrected probably by Dan, is that we will be starting with some site works before the end of this year, hopefully September, October, and there needs to be creation, for instance, around a new car parking to replace car parking that will be lost when the building is built out the front, in front of the building here. And substantial work won't start until early in the new year, hopefully. And completion will take around 12 months, I think, from start to finish. So early 2024 is current estimates about when the building will be completed.
In the shape of agreed services?
Agreed services?
Yeah.
Yes, so
it will be delivered through the unit.
Yeah, so the agreed services delivered, so it's pretty much a swap out of the current mental health facility, except that modelling has been done around future needs. There's the model of care designed for the work within that unit. The design of the building is to support that model of care. You will see in the presentation to come the way in which it's been designed to incorporate different areas within that, so to better manage the different flow of people that we have coming through our unit. So the young, the old, those there that are primarily there for a mental health reason, those that are primarily there for a drug and alcohol reason. So a lot about transitional care, that high-end care of people who need. Hopefully, our services will mean that we'll need less dependence on that type of care going forward, but to work much better with individuals and their whānau for that intensive care at that time in a much more therapeutic environment that will then enable them to a faster transition out of there onto back home again for recovery or to other services for that. So that's the whole thing around what you can achieve when you've got a building that is actually designed around people rather than what we've had in the past. And that's where we've had the benefit of Dan and Nick and the rest of the team to be able to do that.
Very good, thank you.
So I'll hand over to you. Do you want just a quick round the room so we know who's here? Because I'm not sure that Dan and Nick would know everybody that's here. So we'll start with you, Tony.
Trying to keep through the masks.
Well, Tony Koroa, you know me, Tony Robinson.
Kia ora, Heather Robertson. Not related. He's an incident.
Good at calling you both know me, Gavin.
Kia ora, Kim Ngāti Mā Chair.
Morning, it's Kath Long, acting CFO at the moment.
We've met.
Yes, absolutely.
Maureen Ian Diamond, Planning and Funding.
Morena Korua, Ariana Roberts, Planning and Funding.
Morena nei ratimini ki a korua, me mai hara mai wainganui a tātou ngā kaimahi me ngā memo o te puari o Hauora Tairāwhiti. Ratimini ki a koe te whananga e Nick, pai whiwhia, ki a koe anō e te whananga. Ko Josh Wharehinga tōku ingoa, koe tētahi memo o te puari nei. So my name's Josh, I'm a member of Kia ora.
Kia ora.
And the Zoom. And on the Zoom.
Might want to stop sharing the screen maybe.
So can the Zoom just introduce themselves, starting how we're seeing you, Andy?
Yeah, kia ora. I'm Andy Cranston, board member.
Fraser?
Kia ora korua, Fraser Hopkins, comms manager, Hauora Tairāwhiti.
Kia ora, Fraser. Rob?
Morena, Robin Rona, nōna iwi o tūranga, board member. Kia ora.
Hiki?
Kia ora kōrua, ko Hiki Pihema tōku ingoa no te whānau, arua taupare no Tokomari Bay, board member. Kia ora.
Kia ora, Meredith.
Te Marie, kia ora, Meredith Akuata Brown, board member.
Kia ora, Nā.
Tēnā kōrua, tēnā tātou, e hika mā tēnā koe e te whanaunga. Te hoa kura tawhito, e Nick, kai te mihi tēnei kia koe. Mena, I've already sent my question in, mā runga te chat session, so me haere tonu te kaupapa.
Kia ora, and Anil.
Kia ora, Anil, Chief Medical Officer.
Thank you.
Hea korua.
So we have 30 minutes, just under 30 minutes. Go for it. All right. We'll just whip through the slides. Order of affairs, brief clinical planning overview, then cultural input and design and integrity, and then just a little deliverable about some detailed design and just to let you know where the entire process is at. I'm wondering.
It's coming.
It's coming.
Sorry.
It's just seconds away.
Hold the line. Sorry.
So there's the building. So this is just a small selection of the documentation that's already been prepared. So yeah, we'll just flick through as we go. So the site, you're all aware of the process that's led us to being where we are. So the proposed site is just to the south of this building in the car park out the front.
You are here now.
I'm going to stand up because
yeah, there you go.
architects need to point to stuff. Apologies for those online, but I'm going to stand up and point to drawings. Yep, go to the next one. So this is the approximate outline of our building. This is the old Morris Adair, and here's corporate. So there, we go to the next one. So we modified the entry into the car park. We modified the car park. Our building sits here. It's primarily a U shape, focusing on a large courtyard that faces north to grab all the sun. This facility differs from the one in the original business case in that it is an open-ended courtyard as opposed to an enclosed courtyard, and that was done on intense consultation with the clinical and cultural team. It just felt like the enclosed courtyard was not the right model for this facility. It wasn't the message that we were trying to give. So we've done that, and that was a fundamental move early on in the process, and I think everyone's embraced that. We'll move on. So this is the plan. Resolution seems slightly odd, but I mean, basically we have main artia and entry into the facility. We have a whare and tribunal room through here, and then a daily entry through here. We'll get into the design around this artia space and how we control the entry and differentiate between the whare entry and the main entry in a second. Staff facilities through here, some open plan officing, some small breakout rooms and offices, toilets, storage and a kitchenette. Main reception area, central nurses station, high acuity ambulance / police / vehicle admittance for highly agitated consumers of Hauora. They come in through that way. This is the HDU wing, this is the high acuity wing. In here we have 3 bedrooms dedicated, with this bedroom slightly oversized to allow whānau to bed in on a mattress. We have a courtyard, we have an HDU lounge and a de-escalation space, de-escalation room. We also have a seclusion suite in here, and there's been discussion around the inclusion of that in this.
Yeah, we're not using that word.
Yes. And we have an interview room, some storage. Moving along here, one of the differences in this facility is that we have a short stay wing. So this is a set of 2 rooms that also double up as our pandemic response. So we're able to isolate this wing here if we have any Hauora that have COVID or something similar. It's primarily a short stay facility, so it's up to 72 hours for Hauora that don't fit the profile to be in the main facility. So that might be underage, older, eating disorder, something like that, where there's nowhere else in the community for them to be cared for, and then they need safe, a safe place to be whilst we can find somewhere else for them to go. We have a kitchen here that services this large central day room, which opens out onto this big courtyard. There's a separate landscaping scheme for this. That's been part of the work that we've done. And then down here on the east side, we have the general wing, 1, 2, 3, 4, 5 bedrooms. This is a bariatric room, so it's oversized. An activity space, sensory room, and then some laundry, dirty utility, etc. And new plant and equipment, so all the external plant for the facility. We then tie into the existing and build a new piece of link corridor that ties into the existing piece of corridor that remains from the Morris Adair demolition. And that's how the facility is serviced and connects undercover back into the existing hospital.
How many beds all up? The 10?
5, 6, 7, 8, 9, 10. We may need to come back to this plan. It's a lot to absorb, but we have to keep moving.
Can you just? I think it's important, to accentuate, as I was just saying before, around the fact that we've for the first time we've got a facility that is more attuned to the people who will be in that facility. And you're going to be. I'm not going to steal your thunder about what you're going to be talking about, the two of you, about a lot more of that. But I just wanted to accentuate the point here that we've got a lot better facilities and ways of being able to work with people who are more distressed on coming in, either on initial entry or who are staying with us and need that more intensive support around their stay, particularly in an earlier phase of their care, and the ability for whānau to be absolutely alongside their loved ones as they come through here, this part of it. The more usual entry into the unit this way here, the accommodation for those people who are staying with us for a period of time, and that rehabilitative recovery phase there, and improving our capacity to be able to care for those people. A little bit more separate than these people requiring intensive care, but obviously we want the transition from here across to here as quickly as possible, and the building is designed to do that. And then the capacity within this area here as well to be able to tailor the care for those people with maybe different needs that need to be in a quieter and more whānau orientated part of the building, so that they can still be supported through the central core here, but these three components within this building, so that we can actually cover it. Because we have a population utilising these services within Tairāwhiti that is across the whole, not quite across the whole age spectrum, certainly from adolescents right through to our paki care utilising these, and a very much greater requirement around the involvement of whānau within care. So it's how do you create a facility that's designed for us now in the 21st century, as opposed to the current one, which was designed in another country and in a time quite a long time ago.
I mean, that's been something that's been quite important. Jim's 100% correct. Like, it's a Tairāwhiti specific response, design response. And the other point that I'll make as well is that due to the size of the facility and the broad range of Hauora that it serves, and sort of budgetary constraints and the like, this is deemed to be a small facility in the scheme of New Zealand and Australasia. And so what we've the schedule of accommodation, the permitted schedule of accommodation that we're allowed to use doesn't give us the ability to have a specific room for everything. So one of the key aspects of this design has been flexibility. It needs to be able to respond to different requirements as the needs change. And so one of those, we've done that by separating these three areas. We also have the ability to cohort certain sections of this as well. Like, for instance, closing off doors here, so you could separate and protect these two end bedrooms and keep them safe from this if there was a clash. And you can access it externally through a covered walkway and external doors. So we've tried to be clever in that respect to try and allow the facility to do as much as possible. Likewise, we have these spaces such as the activity and therapy, the sensory space, our main day room, our whare, that we're designing in such a way that they are multi-use spaces as well. We don't have the luxury, like I said, of building a million different rooms. So for instance, the sensory room will be treated in such a way that it's 100% appropriate for use as a sensory room, but if needed, it can also be used as an interview room. So it's not going to be entirely clinical. It will have cultural treatment, it will have softer, more welcoming, more calming design elements, likewise with the activity therapy. And in terms of the large sort of open plan day room, the design of the design and selection of the joinery and the furniture will allow us that flexibility, so that as the facility, as they do, you know, as you start using it and needs change, we can modify stuff without huge capital reworks, because we don't get that luxury. Large covered outdoor area as well. So there's a large veranda over here, and this is essentially all glass through here, portions of glass through here. So all of these spaces have access to this outlet and this light.
Sorry, we're not laughing at you. It's the chat.
They can't see where you're pointing, but she's moving the mouse.
Has gone to find his glasses, all's well.
And one thing I missed out was the whānau room. It's a dedicated whānau room, and that's located and accessed off the front of house, but it does, so that allows, you know, for family to actually stay, so they can bring the Hauora in, and it might be 2 in the morning and they've driven for 3 hours from the coast. They can deliver their whānau member and then they can stay the night, and they might stay a couple of days because they need to be there. And so there's an entire room here for them that allows them to come and go as they need to, but then be close to their family member. And so that was one of the areas that was, the location of that became quite critical for safety of these people. What else? We have an exercise courtyard out to the south, and all the bedrooms have outlooks to planted green space. Particularly the HDU has a heavily landscaped area through here. I said we'll get to this courtyard in a bit. I think that's probably about it. Are there any questions on the planning and spatial relationships before we move to the next slide?
Great.
Rachel's just reading through the questions.
There's a question here from Robin. Morena, can you please confirm it's not a marae that is being created in the entry? The general design features might have elements one associates with a marae, but is not a marae.
You want to speak to that, Nick?
I'll probably touch on that when we get to my bit.
Yeah, we have some more images of the atia in the front of the whare, and I'll let Nick speak to that when we get to that. If that's all right.
Thanks.
Please. So we've gone through a zoning. This is a clinical piece of work, and that just denotes risk spaces. So in the background, you know, the plan's been driven early on by clinical requirements. It needs to be fit for purpose. And so one of the activities that we've done is denote risk. So obviously red, highest risk areas, full anti-ligature design, yellow, medium risk, spaces that consumers are always observed to an extent, still anti-ligature, but possibly not to the full extent of the bedrooms. And then the green spaces are low risk spaces, back of house, staff access only. There's a piece of work going on currently around the access control and the security lines and how everything's going to be controlled. We're working through that with Sonia and her team. Just some elevations, they're probably not going to mean a lot. I think we'll put through and work to our 3Ds. So this is our building in 3 dimensions. Here you see the front of house. You see our big courtyard facing north. Corporate is up here. Our general ward or low acuity wing, our high acuity wing, our high dependency admissions, our plant room, our short stay wing. You see it through there. So the general design of it is to keep all the buildings around, all the spaces around the perimeter have been kept quite low and residential in scale, so that the building doesn't feel too institutional. And then you can see in the middle, there's the big double height space, which is the day room, where we want to flood it with light from up above and below, give a feeling of space and freedom. And then either side of it is also the plant rooms. So this building is aiming to achieve Living Building Challenge Core Green certification and Net Zero Energy certification. So we've been working with ACOM services engineers out of Auckland to design all that, and that's from the ground on up in terms of massive amounts of external insulation in the ceiling and the walls and the underfloor to make the building as passive as possible, solar orientation to control, to harness the sun where we want it and to protect ourselves from overheating where we don't want it. And then there's plant equipment that's required to mechanically ventilate and control those temperatures, because we have very specific clinical requirements around temperature ranges for Hauora. So most of those plant rooms, the external plant where possible is located outside of the ground to keep costs down, and then where it needs to service the internal spaces, there's plant in the ceiling space on either end of the day room, and those have external access so that the plant and equipment can be serviced on a daily, weekly, monthly basis without interruption to the occupants. Next. We started to get into the actual design of elements. So here's an early schematic of the entrance, the Aotea space. And I think we'll move to the next slide because you would have all seen the next one. This is the paper the other day. It's probably a good spot to hand over to Mr. Tupara. Start to take us through the next few slides, cultural and their intent in that process.
Kia ora tātou. Katu au ki te mihi, ka te moto mihi ki a maua, kua tai mai māua ki te tautoko o te kaupapa o te whare hau o te huipe. And just response to Robin's question about the marae not being a marae. We sort of have marae and we don't. If we take the concept of what a marae is as a place to welcome people, and we want to be welcoming to people. So in that aspect, yes, it is marae. But in our truer traditional sense, it's not one of our marae that we have in our rohi, of which we have many. But it has a degree of function that impacts on the cultural response that we can make in the new whare. And so on our entrance to the building, there are two. There is the everyday entrance, main part of the building, coming in here, and that follows a paved area based on whānaki. And again, whānaki as a traditional concept, but not taking a whānaki from one of our marae, but developing the hospital's own whānaki pattern. That carries all the essence of what we mean by whānaki and hopefully captures some of what was intended in the model of practice that was drafted up by the hospital, where whānaki is a bold symbol in representing that. We have a secondary entrance which comes through here. Comes through here that actually will go into what's generally being referred to as whare. And that whānaki or that paved area is broken as you come in. And that creates a sense of Aotea. Again, a space for people to gather and where the building and the whānau of this whare can welcome visitors. But it's not intended to be an Aotea of ours in the Tairāwhiti, but just an Aotea space where folk can see the protocols being played out that they're used to when they're welcomed into a building. And they'll come through these large double doors here. I might talk a little bit more about that. Beyond that space is the whare. And it's just whare in the general cultural sense. It doesn't have a tipu in the name, unless the board decides it should. But certainly from a design perspective, we just want looking at the values of whare and how those are common and welcome for whānau that come in there, that it carries all those aspects of familiarity so they can see a piece of themselves as they transition from their community into this space and ready themselves to return to that community. And so whare is a generic term for how we feel connected to places. And we'll go through that when we get into those spaces a bit later on. The front is largely glazed and to allow maximum light to come into the buildings, but we've taken the glazing and added whakairo imagery that gives the face of the building a sense of cultural connection. This is a maho, which will be around the front there, which indicates the maho of our traditional whare. But maho are also about a little space to shelter, a little space to take a breath before you enter into a building. And so again, we take the traditional aspects of maho to be applied to help family when they have to come into the building. And the patterns that we're choosing for that, we're basing on tāneko. Tāneko is a traditional pattern for our culture, but also a pattern that we're developing specifically for the hospital. I'm just handing that around. We don't have too many copies, but copies of the Tairāwhiti design.
I've got two.
Sounds greedy.
Actually goes, the Tairāwhiti design goes like that. And it begins to introduce a sense of tēnei te pō nau mai te ao, that from the darkness, from whatever space of your anxiety, from that condition, moving into a condition of well-being. So tēnei te pō nau mai te ao, welcoming a lighten. So we have a contrast of dark and light. We're treating the dark for what it is. We're not trying to tuck that darkness away. The darkness is why you come. But we're acknowledging what that is and that your journey at the end will have the light. And so our Tairāwhiti, as per the model of practice, will start right from the car park, lead you across the forecourt and into the building and continue on into the whare itself. And our tāneko pattern as well acknowledges in the contrasting colours the darkness as well as the light.
That's just some solar studies, don't worry about that. No, you stay here, please. And so we've had several cultural meetings with the cultural team that have been, stay here, that have been very, very productive. And we've had some great dialogue through that. And I think I'll just let Nick keep talking and then I'll jump in on the biophilic work. Which is
probably the least interesting image.
There you go. That's just to prove we had some meetings.
Okay, this will be fine.
Yeah, so this is where we started.
Hey, get your piece already. Right, the two entrances, the first one, the everyday entrance, comes into the building and is brought in by a Tairāwhiti. And that Tairāwhiti carries on inside and it carries on through the whole length of the whare. And so every part of our whare is as significant as the entranceway. And it's symbolic of the journey one takes through our whare to our being. It also recognises a traditional concept around tahu. When you go into a meeting house and the backbone of the house runs the full length. And so we wanted those elements of familiarity to be with whānau when they come in, that this whare is important to our being as their own whare nui at their own marae would be to them. From a structural perspective, there are pau that hold that tahu up. And we could have just had We could have had posts, but instead we've decided to make those and fashion those as putorino. And putorino are a traditional concept that comes from the moth, that when a caterpillar turns itself into a cocoon, chrysalis, then it becomes a moth.
Can you hold it up to the camera so that the room might be able to?
Yeah.
You bring it down to here. Sand and drying, yeah.
Can you see?
There we go.
So we've decided to take the putorino to hold the whare up. And that whole concept comes from a tipuna of ours called Hine Raukatauri, who's the atua, or the creator of music. And we wanted music to be the creator of this whare. It's tipuna, but it's not the tipuna of Poho o Rawiri or the tipuna of Te Poho o Tāmanihiri. It's a tipuna that belongs to everybody. But transformation is another thing, from the dark to the light, from a caterpillar to a moth, and the transition from anxiety into well-being, and using this form as a method of holding up the whare. The fabrication of these is a discussion we're currently having, but there are 6. We have an opportunity to put 6 of them into the meeting house. Hine Raukatauri is also female. And when discussions with the cultural team, having strong feminine elements in the whare was seen to be important. And so there's a feminine elegance to this form, if I can put it that way. And so we wanted to capture those sorts of things throughout the whare. And that gives you an idea of the cultural direction we've been taking. It's not all of it, but it's a snapshot that we're presenting here today.
One of the things that Nick was adamant about early on was that this building didn't just have a great entry, a main day room that had some cultural treatment and a courtyard. The whole facility needed to be ingrained in the design of the whole facility. That this was a Tairāwhiti space. And so this was an early diagram of how we were going to ensure an authentic cultural overlay. So all of these lines represent areas or cultural interventions, be that whāriki on the floor, some kind of treatment, be it mats or patterning or colour. All these lines are areas where the walls will require some kind of treatment. And that might be in terms of its colour, in terms of the acoustic panels that go on it, in terms of the patterning that might be on the wall. And it was important that these spaces were had a hierarchy of design so that you could use it for wayfinding and identity. And that was important for having 2 sets of pattern as well to sort of give the spaces hierarchy as well. And you can see here, you know, in the back of house, the staff area gets just as much treatment as the rooms do, or the day room, because the people working here day in, day out need that care and attention and need to feel grounded and identified with their space as well. So that was, we've really tried to hold on to that intention from the start, whilst integrating ideas of puna and orientation and identity that came from the business case as well. So it's kind of a hybrid cultural overlay, trying to incorporate these elements in a coherent, systematic way.
It's picking on what, when you go into, traditionally when you go into a wharenui, and all the whakairo, the tukutuku and the kōwhaiwhai are parts of the building. They're part of the integrity of the structure. And so we're hoping that wherever it is possible, that design and structural elements have embedded in them cultural design. And that we're not bringing in artwork just to hang on the wall. The wall is an art piece in itself. So, and that lends itself to the maintenance and the upkeep of the building as well.
So just a languaging thing, which would you characterise this as a cultural overlay or a cultural underpinning?
Oh, it's definitely an underpinning.
Yeah.
And I think it definitely has to, especially with the community that this whare looks to support. And yeah, I think we need to be bolder than perhaps been in the past. Not to say that mahi toi can't continue to have some role and be added in there, but the building itself speaks for itself. As a whare nui speaks for itself.
That's just another development. So there's been multiple iterations as we work through with the cultural team. So sit down, have a chat to them, take on their comments, go away. We work through stuff, we bring it back.
Certainly on this one, you can see the two entrances quite clearly with the whāriki running all the way through on the day entrance, but on the marae, by breaking the whāriki pattern, you create an ātea as it's needed. And the whare doors would, in a welcoming protocol, would be opened, and then that whāriki continues into the building in that way. And in that case, neither entrance is trying to supersede the other, but when required, each is important to who your visitors are. And we hope to carry some of that even up into the ambulance bay. That a person deciding to arrive to this whare by that entrance also has cultural context for them. And given the level of distress they might be in, that cultural context would be useful for them to step out of the vehicle and step in to a cultural context for themselves. So even considering that entrance as well.
I think Na's got a question.
Okay, I'm just going to put my thoughts forward right now. I have to bug out. Got another something I have to do. But Nick, rawe o whakaro, rawe o kōrero, I wanted to just say, you know, we need to be thinking, you know, 21st, 22nd century stuff. But more importantly, how is your kōrero going to be carried when, you know, after the building's up? So I'm suggesting to you that the effectiveness of, you know, ngā tukutuku, ngā whakairo, ngā whāriki is only as effective as the kōrero stays alive. Otherwise, you know, he pikitia noiho. And so I just wanted to ask, is there it might be Jim I'm asking actually, but is there a thought around the whakawhānui te kōrero, moenei āhuatanga? Otherwise it's just left standing on the wall. So post-establishment, of course, there's got to be that continuation of the whakaro, because now I'm trying to think in my mind about, you know, the users of the service, you know, and I think just by way of explanation to them around the kaupapa ngā tukutuku, ngā whakairo, hei awhine ki a rātou i te wā oranga. You know, it's another opportunity to assist them into their wellness.
Kia ora, Fernanda. There probably is a Jim question, but it is about cultural change. It is about implanting not only the mahi toi into the structure of the building, but also the mātauranga that comes with that toi. And it's hoped that the kōrero actually becomes part of those that work in the whare. So they become the carriers not only of their clinical understanding or support for families, but they also support their whare. And some of that's going to be cultural change. But we have the grounding for it, and we have a depth of grounding that this place becomes a whare wānanga for Hauora. It becomes a whare wānanga for the way that this community thinks about the well-being of those that come to it. And the cultural change between just being a medical delivery service to being whare wānanga, I think, brings life to the whare, brings connection for those that have to come to work every day in that whare, and the way that they interact with the community that comes to visit them. And so wānanga needs to be, in my view anyway, a consideration in the way that we open and operate the whare.
Yeah, and so this goes, and that's why it's a Jim question. This goes to the model of care. It's not simply a clinical model of care. It's a cultural model of care that needs to be encompassed into the overall design and completion of the tēnei whare. So, yeah, that's kind of what I wanted to just impart. Madam Chair, I do have to bug out. I've sent Rachel my kōrero for the in committee spaces, and I think Josh is also there able to assist in that regard. All right.
Kia ora, for, thank you.
Ka kite koutou.
That's a technical design.
Can you see it?
The beginnings of one anyway. Okay, and this is the whāriki one. And it will be on that angle as well. The whole push for whāriki to run through the length of the building is based around what Ngā was saying. That a whāriki tradition is laid down, particularly when receiving care, rongoa, tāmoko, or just to kōrero, everybody who chooses to sit on that whāriki indicates to everybody else they are invested in the well-being of the taupapa that's there. And by having the whāriki run the entire length, it indicates that all those that work and come into this whare are investing in the well-being of the whānau that come into this place. And when I saw the model of practice, immediately jumped on everything that comes with the symbol of what whāriki is.
Fine.
Yeah, and so, you know, and this is just a snapshot in time of the preliminary design phase. So this is where we spent attention on these spaces, on the entry, on the main courtyard, and the landscaping around that. We recognise fully that the ambulance high acuity admission area is yet to be tackled, but it was important that we set the tone for how we were going to deal with the spaces before we got to this space and also the HDU courtyard, because we needed to have a language in place before we tackle those two spaces, because they are so much more clinical in their requirements. It would be really easy to lose touch of what we're trying to achieve in there and have all the meat stripped out by clinical requirements. So those are the pieces of work that we're looking at in the next phase. And this is by no means an exhaustive diagram. It's just part of the design process.
Okay, before you change, can you go back? I'll just point out the pau, the pūtorino, are these circles here. So again, they run the length of the building. And so there's two present in the day room, and also from the day room out into the courtyard, and there's two present in the courtyard. There's one to welcome people in the maho up the front, and one in reception, but that one is moving up and down at the moment, depending on how reception is finalised. But they're quite substantial in size, and we'll see that in the next.
So this is the early kind of looks and feels.
Yeah, well, this is two views either end of the day room, and you can see the pūtorino here. And they'll rise up to the ceiling. I think in the day room they're 6 metres plus in height. So they're a little bit imposing, but they're ensuring that the cultural message is part of your space. You can't be in the space and not feel some kind of cultural connection. Even to the point where on the ceiling, the acoustic tiles continue on the kaupapa of music in that space.
Here we were just looking at some of the materials and the possible way that we might manifest some of these items. It's all a work in progress, but the cultural advisory panel have been very receptive and encouraging thus far.
Certainly, this is just to give you a sense of the profile or the silhouette that a pūtorino might have.
And this is just a further step that the landscaping team have been working on. So there were early sort of schematics of how the courtyards and outdoor spaces might work. And now they're taking that to the next level in terms of actual nitty gritty. So levels, materials, specific plants, that kind of thing, the furniture and the design. So we're really excited about the next phase because that's when we're going to dive into a lot of that detail. As certain areas get signed off and approved, we can then keep moving.
You'll not, let me just get back. You'll notice there's a puna, there's a water source in the courtyard. There's also one in the maho where the first pūtorino served. A water source for whānau to just interact with water, but also to sprinkle themselves if they feel the need to. But having water, and water movement in the space is also something we're growing at the moment.
We like the idea of sound, the light reflection, even the smell, just the calming nature of it. And these are just some early images. So back to the architect, more in words. So part of this process is this living building challenge core requirement, and one of their key drivers is biophilic design. So biophilic design is how you integrate nature into the building and keep personal connection with nature throughout. And so they have a prescriptive pathway that you move through to ensure that all the stakeholders who are involved in the project are on board with the idea of biophilia and the benefits that it brings. By the time we got to the point of the biophilic meeting, we'd already had several cultural meetings. And what we found was, by and large, biophilic design is iwi-led design. They're almost the same thing. And so we found this, this really nice kind of overlap. And the whole biophilic workshop process just sort of flowed through. We'd already kind of got to a lot of those decisions. We had to have connection to the sky. We had to have connection to the plants, to the ground. We needed water. We wanted real materials. We wanted to track the seasons. We wanted to track the day and the light. We wanted fresh air. We wanted all these things. They were already there. So it was really kind of just a reiteration of that. Unfortunately, in the world of architecture and compliance, you actually have to do tables and words to prove that what your design is doing is achieving this and justify how that happens. So this is a significant document in this process in that what we're trying to bring together design elements, what they mean culturally, the various guidelines, design guidelines that the Ministry of Health or Health New Zealand require us to reference in our design to ensure cultural integrity. And then there's a biophilic framework and the various elements in biophilic design that our gestures need to rely on and relate to. So this is essentially a piece of programming to capture all these ideas that have been flowing and then to make sure that we can then assign ownership of delivery to each of those elements. How are we going to make sure that it doesn't get value engineered out through the process, that it doesn't fall by the wayside because it's too difficult? So it's assigning someone to make sure to champion that cause, develop it, bring it through to completion, so that the original intent is as intact as possible by the time we get to the end. So you can just skip through that. There's like 5 pages of it. Multiple bits and pieces, and Nick's been really good.
Sure, it's there.
Yeah, Nick's been really good at helping us get through that. This is the last little bit. This is more clinical. So if there are any cultural questions, now's a good time for that.
I've got a comment, not so much question, but a comment, and it goes back to what I said before. I'd really like the languaging to change from being a cultural overlay to cultural underpinning. I think all of us have been involved in building projects where there's been cost escalation along the way. None of us will be here to champion for not chipping away at overlays. So I think that's really important to couch this as fundamental to the integrity of the facility and to give effect to the model of care rather than as an overlay.
You got it, Kim.
Raised your hand.
Miracle.
I just wanted to know how confident we felt that it's underpinned also the cultural kind of capture of our region and its changing ethnicities too. I mean, I'm really, really loving the whakaaro and kaupapa is this whole, sense of the spiritual, the connections, etc. And I'm just wondering whether we are confident that's because, we get feedback, often it can be negative, as to when we indigenize spaces for those who are still trying to figure out their indigeneity. So are we confident that we are indeed meeting the changing landscape of our community with this project, noting, that I just, part of me is just thinking, I don't want to see a reinforcement that Māori are the high health user of the space. Fundamentally, that's an adverse kind of maybe kind of construct in my head, but that was my thought, was just confidence that we are ensuring we meet the whole demographic, I guess, and cultural ethnicities of our region as this is changing. Kia ora.
Is that a question for us? I think so. Well, I'll try to respond. Thank you, Meredith. Certainly the idea of whāriki cuts across many cultures. The fact that you have a mat to play on in a child's bedroom, or you have the good mat in the middle of your lounge, that you welcome important visitors to your home. Whāriki, although we're carrying the kupu Māori, mat or sharing space or connecting people to space cuts across culture. And even a pūtorino, again, we're using a Māori kupu, but a caterpillar transitioning through a cocoon into a moth is something that happens in all cultures. And the way that we can express it, it has a taha Māori side, but many of these concepts are universal. Music, connection to nature, to water, the sky, to seasons, to light, are all multicultural aspects. Our kupu Māori, because we're in Aotearoa, but our cultural concept is far more reaching than that.
I guess that's the confidence we have in these frameworks, is that it is overreaching in all spheres of ethnic. So kia ora to you, Nick, and kia ora to the mahi, the team are doing in that space.
So just to open it up, if anyone has any questions or comments to make to our wonderful designers, architects, cultural inspirations.
None of the aerial shots show any solar PV. Is there going to be stuff on the roof?
The entire roof is covered in PV.
Oh, cool.
And the hospital link. And we're still looking for another 50 square metres where we can put some more panels.
From my place.
Yeah. Yeah, it has to be on our site, unfortunately, for it to count. But yes, so part of that's our key device for net zero energy is PV.
Wonderful, wonderful.
And just as an indication of the amount of passivity in the design of the envelope, because that's the other key thing. If you're building more efficient, you're going to use more energy to keep it at stasis. So I think the roof is somewhere around R9 and the walls the same, which represents about 3.5 times above current standard. So they're sort of this thick in terms of insulation.
Does anyone on the Zoom have a question?
Sorry, Meredith had a question a while ago. Is the age for the service from 16?
Oh,
it'll be very flexible, Meredith, depending on the person and the whānau and the supports and the issues for that individual. But yeah, we retain the capacity within the children's ward to also accommodate younger people. But, you know, the whole point about the design of this is to create spaces that will work for different age groups, different needs of people. And of course, that will also, you know, accommodate, you know, other people that will be using this building as well. So, yeah, that's the whole ethos of the building.
Yeah. No, thank you, Jim. Yeah, thank you for bringing up that question. I was just thinking from a youth angle, respect to those spaces being kind of breakout spaces of sorts to meet those needs. So, yeah, kia ora.
Okay, so if we don't have any further questions, thank you very much. I am conscious that we need to kick on with our business. So thank you very much for joining us. And I think fair to say that you've left a happy outgoing board here and seeing what it's going to be possible.
Could we ask the patterns have currently not been released?
You can have them all back. Return all copies.
So we're still working with the cultural team to ensure that they're affordable.
And it must be your first evening. Sorry, this is.
Oh, right. Thank you.
Okay, thank you very much. Andy, did you have something?
I did have a question, but it's outside the footprint, so I don't need the designers in here. Jim did mention at the start about the parking issues, and that's going to be an overnight issue. As soon as the tape goes up, there's going to be a lot of parts lost. So have we got solutions, short term during the build, but long term as well? It kind of looks like it might be a land requirement.
So the plan is to create the new car parking ahead of the building's, you know, proper starting, so that we actually, you know, replace out, I think, like or slightly more car parking on site than the previous. So we get a jump ahead of that. Yeah, because car parking is an issue on site. The main issue around car parking on site is the need for people wanting car parking as close as possible to the building as possible. So we don't like to walk. Yeah, so that's something we have to do. And just we've got areas of the site which will be converted to car parking prior to building commencing.
Oh, Andy, you're on mute.
Yeah, there will be a net loss from this build, though, won't there?
No.
On the actual location?
Where the actual building is going, there'll be car parks that will go from there, but they'll be replaced ahead of time with new car parks.
Whereabouts?
I don't think they've finalised them, but probably along opposite where the along the front of the hospital, where the helipad is, on this side of the helipad, on that side of the road along there.
Oh, really?
Yeah.
I would have thought there would be distance requirements from the helipad. That's it.
Yeah, yeah, but they'll be, yes, slightly down.
I'm sure that
Okay.
Shortcuts.
No.
Okay, so let's move on. Our paper on carbon neutral program. Just noting that it is referenced as an in-committee information item, but my understanding is that the direction that's attached to it has been lodged in Parliament, so it is public information. And it's simply that, just a direction that is requiring us to provide an annual inventory on emissions targets, emissions reduction plans, and annual reporting. Is there anything further that we need to?
No, it's predominantly around, so I think there's a get out of jail free card for the first year, but I think it's just ensuring that as we transition to carbon neutral, that we are keeping accurate records of our emissions and stuff, and that we are able to pull that together as a whole of government paper. So that,
and this will all, our contribution of this will become part of Health New Zealand's emissions reduction plan. Does anyone have any questions on this one?
I could probably just comment, having just worked through this exact same thing across the Trust and Eastern Group. Don't underestimate how hard it is to aggregate the Scope 1 information and make sure you think hard about how you get the work done at source, like trying to do it collate it and figure it out at the organisation you'll have to start with is really, really difficult. And the only way you can really get this working efficiently is to make it part of the procurement processes so that it's naturally in the supply chain. Tell us how many units of stuff you sold us, as it were, and tell us, give us footprint or whatever you need for the. If you don't embed it at source with a mature supply chain conversation, it's really challenging to do. Just and the size of this organisation be mind-boggling.
Here's the beauty of Health New Zealand.
The
whole procurement team.
That's the theory, Jim.
That work.
That is the theory indeed.
Yeah.
That's good advice, though.
And if you do want to come and chat to the team at Eastland Trust who've been through this voluntarily as part of the Climate Leaders Coalition, I'm sure they'd be more than willing to share their journey, if it's of any benefit at all. Don't know.
Okay. Did anyone else have any comments on the carbon emission paper? Okay, so we'll move on to the Hauora Tairāwhiti Reform Transition Plan, which is at page 45, which I referred to a bit earlier in the morning, but this is just a bit more detail around actions that need taking or figuring out as we lead up to 30 June. So Jim, is there any comment you wanted to make on this one?
I think just as you said before, we're just wanting those last little pieces around some of that, the specifics around our subsidiary entities and what we have to do about that. So I was part of a hui on Friday morning for shared service agency chairs and just talking about, they're a specific group. They're all going to go across to become management parts of Health New Zealand. So the separate nature of those will be resolved over a period of time. But as you mentioned, there may be a requirement for some arrangements around that. We need to look at the constitutions of our subsidiary companies to make sure that we've got everything that's required covered off within that. So there's still a piece of work there, and we keep getting promised. This is what you're going to have to do. But
I think one of the material things for us in that is, we've got no clarity or understanding about directorship positions on our subsidiaries. So Gisborne Laundry met last week. And one of the things that I've indicated is that in the event we're needed beyond 30th of June for an interim period while that gets sorted out, then Tony and I will be available to continue as directors for a brief period while Health New Zealand makes decisions around its directorship arrangements. And I expect TLAB will no doubt be having similar kinds of discussions about governance going forward.
In the same position, so I think we've got a meeting coming up shortly.
I think probably for all of us, we will be happy to back out at 30th of June, but are not going to leave our subsidiaries in the lurch.
Right, total that.
And I guess the other thing on this paper too, Jim, is Jim and I will be sort of having review. We touch base every week, and we'll be doing touch bases on critical aspects of this, things that are at risk.
Just from this morning's conversation with CFOs, a template for the letter of representation. It's not really a letter of representation. We'll be coming out today.
Okay. So that we need to sign that off at our next board meeting.
Yeah, we also have the capacity or capability to change it. So they're not, if there's elements that we want to identify and highlight as risks. Then we've got the ability to add that into that letter.
Yeah, because it's an ongoing letter of representation, isn't it? Essentially, which is
they have changed the wording from the original.
Not one we can really promise from the 1st of July.
No, that's to the best of your knowledge.
This is the situation. I look forward to reading that one.
And so
I'm sure Tony will be all over it for us.
As soon as it comes.
And that will be, to the best of our knowledge, over the 11 months ending.
It'll be to the period end, and I think there will be a statement that as of the final board, you're not aware of any circumstances that have arisen between the end of May and
And someone else will cover the going concern funding commitment component.
So we will need to make sure that when we consider that paper and formally agree to it at the next meeting, that includes disclosure of any items from the end of May until the 28th of June that we sort of need to formally note.
Cool.
Okay. Anything else on this one?
Well done.
Okay. Any questions, anyone on the Zoom? The room? No. Jim, I'm going to pass over to you for the paper on vacancies and recruitment. And I guess just the one thing I'm hoping that you might be able to talk to us about in the context of this paper is going forward, what are the elements that kind of reside locally and what reside in Health New Zealand's workforce plan and recruitment strategies and that kind of thing?
Yep. So yeah, I'll take the paper as read there. It was an opportunity to give you a snapshot of what was happening at that period of time that the paper was put together. You can see that we've got a quite considerable vacancy rate currently, higher than what we've normally been having. So that is making an appreciable difference, and you'll see that allowing from the different sizes of the workforce across, obviously nursing is our biggest workforce, but you can see that it's proportionately a similar problem across the whole organisation. So it's not just a case of, we can't recruit doctors, we can't recruit nurses, we can't recruit allied health. It's difficult to recruit across those other areas of non-health support and management admin as well. And it's symptomatic of what is happening within the health services and what's happening within the community as well, to be able to recruit people in. So that being said, it is really, the question there is around, what we're doing about it. I've covered off, there's an immediate impact there on our team within the organisation, with our people development team, because there's a lot of churn. We've got, not only have we got vacancies, but we've got a lot of people who are shifting around within the organisation. So they're people who have decided, I've worked in this area for a long period of time, it's now for a change. I don't really want to leave the organisation, but I also want to get something different happening after the experiences that they've had. And so we've got a lot of turnover and churn there within the organisation as well. We can't get away from the fundamental problem that as a country we haven't trained enough people within the health system over the years. We've had a few attempts at being able to scale that up, but we haven't, clearly haven't cracked that. And when the overseas pipeline was turned off through COVID and still remains comparatively off, then it's really highlighted that problem that we've got there. So while the old saying goes, the best time to 20 years ago, the next second best time is now. We also have that very much with staffing the health system. Now is the moment that we need to be getting more people into the system. So we have been working around with Hauora, for instance, to encourage more young Māori, or not just young Māori as a whole, into our system. We have been specifically recruiting people, and the 30 additional people we've just recruited to help us over the winter period, but also with a view to those people coming into our system and then moving on to health careers, and providing support around that through our Hauora staff and our staff within people development and generally across the organisation. And we're working with the education sector around gateway programs, so providing opportunities for people to understand and develop an interest in health across the whole rohe as well. And a group of us were in just 2 weeks ago talking with Ngāti Hauora around the large number of young people in secondary education on the coast who would make excellent candidates for working with Ngāti Hauora in the future and elsewhere within the health system, and how we can attract and support people in there. So looking at, for instance, working with Te Pūkenga around the programs that they offer around how they can be structured over a longer period of time for people. So traditionally, our system was traditionally designed around people leaving school, doing a 3-year degree program or technical program, and then joining the workforce after that. But we know that we need to cater for people with lots of other considerations in their lives, rather than just going off for 3 years or 4 years or longer to Otago University for a bit of fun and developing one's future at the same time. That's not practical for many people. And how do we create practicality? So we're just talking here around maybe up to a 5-year nursing degree for people who are able to work with us, able to be supported with scholarships and through Te Pukenga, talk with our iwi colleagues as well about how we can support people through that, to become a registered nurse or a paramedic or occupational therapist or a physiotherapist, etc. Of those roles. And of course, those programs are also changing. There are 3 different programs within that Te Pukenga is developing out around nursing programs to make them more realistic and able to be followed through for people wanting to go into that. So how do we redesign jobs, but also and the system, which we're doing, and how do we actually redesign tertiary education to make it work for people as well? So that's important there. We're also redesigning the way in which we carry out the work to enable our short. We absolutely, for instance, and I've given the case there around midwifery, we absolutely need midwives within our services. We absolutely need Māori within our midwifery services as well. So how do we redesign the service to focus on our short supply of those while we're training more? So we've utilised more registered nurses, we've utilised more healthcare assistants in that service so that we're able to keep it going as we go through that really difficult period of time we have now and going forward. And then we've got a program on to attract people in the more general terms to come to Tairāwhiti. So we've got a recruitment promotion campaign that Fraser could talk a little bit about at this point, about what we're doing there. Fraser?
Yep, sure. So last week we were presented 4 creative options for a national recruitment campaign by Woods Agency. So ourselves and the recruitment team chose one of those options for further refining. And so we are expecting before the end of June to go out with a national campaign drawing people in to the benefits of working in Tairāwhiti and at Hauora Tairāwhiti, leaning into the things that we living in Tūranganui, Kiwi and Tairāwhiti take for granted compared to the larger regions such as work-life balance, traffic, ability to make a difference. So watch this space and I expect to share the refined option with the board before the end of June and open for feedback as well.
Fraser, that sounds great. I guess my question is, how does this fit with Health New Zealand overall recruitment approach? Because no doubt they will be wanting to, take the edge off competition in the recruitment process around the country.
Yeah, I think it fits quite well because they're also needing, because their requirement is to make sure that every part of the system is staffed. So they actually need to be assisting us to make sure that this part of the system is staffed as much as the larger centres, which do in general often find it easier to recruit. So that they're going to be wanting to support us in enabling people to be here because they need to make sure that the system works everywhere. Mantra is, wherever you live, you can get access to health services. Where your postcode is no longer a barrier to accessing services. So Health New Zealand are keyed into making sure that they support the recruitment and retention of staff across their whole network. So different era.
Right. Leave that with you as an operational matter.
That's the same question. I haven't read that part of the paper. I thought, well, we're doing all this mahi, but Big Brother's taking over and that's their obligation. I hear what you're saying, Jim. I was struggling to reconcile the two.
Or Big Brother or Big Sister, as the case may be.
Uncle.
It's got a responsibility to make sure that all parts of the system are working.
And I can see the benefits, but the tension.
Yes. Yeah. Well, we've lived the tensions the other direction, where there's been recruitment campaigns that have recruited people and they've staffed up nicely the main centres. Different world now. We need to be staffing up nicely across the whole system.
Other regions are actively pursuing recruitment campaigns as well. So it really seems like a get in first. You have to be in. So if we're not doing anything, we're going to lose out.
Yeah. Reminds me of the game we used to play at primary school where you steal the balls from other people's plate and you run and steal the balls. And
yeah,
okay,
very much like that.
I think that well, you know, as a board, our interest is in attracting staff here and going forward. I guess this is a matter for Health New Zealand.
Yeah, I mean, we've got a range of things that we want to do. You know, we very much believe that we've got talent in our local community, and that's our first, you know, that would be our, it's not quite, you know, get them tomorrow, but if we don't put a lot of effort into that, we need to, convert, you know, in very basic terms, convert our talent locally into the future workforce, be it within the hospital, of course, or in the health services, or be anywhere in Tairāwhiti. That's, you know, we've got
and
an abundance of young people.
Tairāwhitians.
They're the sticky ones, if you want to use that phrase. Yeah, absolutely.
Okay. Does anyone have any comments or questions on the recruitment paper? Andy.
Yeah, thanks for that. The root of the problem still exists, though. It's Aotearoa has not trained enough people.
Yeah.
Has there been any consideration of supporting training with bonding, which, you know, could be quite a good initiative to get people's funding costs? And the other thing is we're doing the national promotion to get people to Tairāwhiti. I think nationally there is a reasonable amount of awareness of Tairāwhiti, but what's happening with international recruitment, because that still seems to be really difficult for even nurses to get through that whole process of coming here and working here. So two things there.
Yep. Bonding. So the voluntary bonding scheme still operates. So for certain professional groups, there is quite considerable. If you get recruited, there is different categories of nurses and doctors and other health professionals. If you can get quite considerable money back on your student loans, although that, of course, these days not so much of an issue with lower fees, but definitely quite invaluable. So bonding still does exist within the system. Access to the country, so the recruitment drive that's going on at the moment around ICU nurses in particular has brought some candidates here for Tairāwhiti out of the total pool of people. I don't know if we've actually I can't tell you whether we've actually recruited any of those people, but definitely there's been some candidates introduced to us here out of that process there. It is and has been I wouldn't say easy, but it is possible to get people in, and we have recruited quite a number of people over the whole pandemic period. So that has been carried on at that time. I think the issue that has been raised is around that faster access to residency in the country. That rather than actually getting in the border at the first place is the thing that was complained about in relationship to nursing. So we'll see what happens around that.
Yeah.
Okay. Kath, we did touch on the financial report earlier. And I know we talked about it at FRAC. We did note that our forecast deficit position has deteriorated a bit. No one had any particular questions that they had raised. Is there anything else that you would like to highlight for us?
No, just on the deficit position, it's known issues, as I've been saying, over the past couple of months. We are undertaking a piece of work to identify, so there are some staffing costs that relate to COVID that have not been coded through to the COVID cost centre, so we haven't picked them up. So we're doing a piece of work on identifying those costs and making sure we move those across, because they'll bring in extra funding and will help that deficit position. So straight with cleaning, orderlies and security, by and large, have not been coded anywhere near COVID. We've been using them to staff the doors, do patient transport, and clean facilities for. So I'm just working on that there. So that will hopefully improve the position somewhat. And then we're just working through items we're holding on our balance sheet as well, as to whether we need to be holding them still on our balance sheet. We'll do, which, Health New Zealand are going to be wanting a thorough review of what we're holding in our liabilities. So we'll go through the items, because every now and again you get something that just gets stuck on your balance sheet.
You said holding, I thought you said hiding.
We don't hiding.
Hiding?
Okay. Thank you, Kath. Look, so that brings an end to the public session of the meeting, unless anyone's got any public general business items. Okay. So to any members of the public and the media who are still with us, thank you for joining us today. I'm particularly glad if any of you were there for the presentation of the mental health facility. I think that was a great presentation, and really looking forward to seeing that build as it occurs over the next few years. So I'll now formally move us into public excluded. IT, if you can